Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki eko weshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Morning, bienvenue, welcome everyone. Welcome to Family Medicine Grand Rounds. My name's Doug Archibald, and I'm the Director of Research for the Department of Family Medicine here at University of Ottawa. And it's my pleasure to introduce our speakers and to moderate this morning. So first up, we have a group of physicians from the Civic campus, and that's Dr. Jason Trickovic, Dr. Laura Cummings, and Dr. Victoria Swan. Jason, Laura, and Victoria are family physicians with a focus on interprofessional collaboration, working to thoughtfully incorporate point-of-care ultrasound into family medicine. And today they will discuss their practical experiences and ongoing research from the PoCUS, point-of-care ultrasound, project at the Civic Family Health Team. And they're aiming to understand its role and benefits in daily medical practice. So Jason, Laura, Victoria, welcome, and I'll hand things over to you.
Hi, everybody. My name is Jason Trickovic. Already here, see. And I'm one of the staff physicians at the Civic FHT. And today we wanted to give you an update about where we are with family medicine centered PoCUS. Sometimes we call that FM PoCUS. And we're going to be talking about us and maybe some of the other sites that are actually involved in this initiative. Today, I'm presenting along with Dr. Swan and Dr. Cummings, who are both IP certified PoCUS users and really add a lot of different tremendous value in different ways through obstetrics and quality improvement initiatives. So we have no conflict of interest to declare today. And, you know, in addition to, you know, everybody that's been involved with this presentation in particular, I wanted to thank Usama Utbi from the Riverside site. He showed great interest in getting involved in PoCUS and has attended many of our meetings. Adam Jones Delcourt, one of the leads out of the Winchester site, has been a pioneer in bringing PoCUS to our curriculum, and Paul Oshinsky, one of my former colleagues from the University of Saskatchewan, who is an ultrasound director out there, and also the whole Civic FHT, because our Our group is very open to trying new things and has been very supportive with this, so I say thank you. Obviously, all the other people, all the residents that have been involved in research, we thank you too, and you'll get to see a little bit more of what they've kind of been working on. So today, I'm going to talk about measuring our gains, how we used a family medicine-centered PoCUS logic model to objectively kind of track our success, increasing our depth, so how we're using research to kind of deepen the understanding of FM PoCUS, and then improving our technique, which Laura will talk about iterating, how QI and QA helps us iterate the program into making it better. And then I'll end with some next steps. So first, measuring our gains. A little bit of a switch on here. I'm going to start with a clinical case to get everybody acclimatized to family medicine centered PoCUS. So here's a story of a 46-year-old male who presents with a 4-week history of flu-like symptoms, cold-like symptoms, but in the last 2 days starts to have a productive cough, has some pleuritic back pain, right-sided back pain. Doesn't report a fever, but the night before does report kind of some night sweats, some fatigue over the last week, has a pretty unremarkable past medical history of just exercise-induced asthma. And, the clinician on exam does vitals and patient's afebrile, normotensive, pulse is regular. Respiratory exam is perfect. There's nil of note there, as well as the cardiovascular exam being unremarkable. Clinician decides to use PoCUS at the bedside, and this is a true case, by the way, and he finds this. And I know this is a little bit kind of complex for maybe people that haven't had a chance to look at lung ultrasound, but let me just try to outline some of the things that we have here. This is a view of the right lung. And what we see at the top there is some ribs. Those are those kind of hyperechoic kind of, round structures, and under that, the pleura, or the pleural line. And under that, where these orange lines are, this is A lines, what we call A lines, and this is aerated lung, this is normal lung. But if we look over to the left, what we see is that there's some type of mass or lesion that's hyperechoic, and underneath it, there's this enhancing artifact, which likely is confluent B lines. So this is what a pneumonia would look like, okay? And maybe I'll just, after I've done that, I'll let you see that again. Maybe it becomes a little bit more apparent when we look at it, knowing exactly now what we're looking for. And so this, user or clinician is new to PoCUS, so he decides to order a chest x-ray and starts the person empirically on amoxicillin for 5 days. And on that 5th day of the antibiotics being completed, the x-ray is eventually reported and it's confirmed to be a right upper lobe pneumonia. With respect to bacterial pneumonia, ultrasound performs x-ray all the time. It has sensitivities of 94 and specificities of 96 when thinking about bacterial pneumonia. And for those that look at likelihood ratios, a positive and negative likelihood ratio of 16.8 and 0.07 respectively. And if we look at all the studies and we look across the gamut, on x-ray's best day, it reaches almost a sensitivity of around 75%. And on ultrasound's worst day, it's up at 81%. So, this is an interesting comparison. And, what's funny about this story, and you can't make this stuff up, is the patient was actually me. In early April, Doug might remember me hacking on a phone call that we had. I had pneumonia, and this was my case. And obviously, we don't want patients ultrasounding themselves. That would be ridiculous. But in the hands of a family physician, this scenario kind of comes to mind. And I think this is the one that jumps to mind, is that we could avoid getting x-rays. And then the next step that we think about while I've been working through as a patient, the patient flow is, well, what does that mean to the healthcare system? And, it's a small cost of $33 that we're saving. The patient may or may not be saving 5 minutes of time. Per patient, we may argue that's a big thing, but their satisfaction is maybe a little bit better than if they didn't have ultrasound, and the patient's maybe saving a morning of not having to spend time going to the x-ray, and they're a little bit satisfied. But really, that's not the use case that I think is really important. It's the one that we're trying to avoid people going to the emergency department. And we can imagine a scenario where somebody like me presents atypically, no fever, respiratory exam is perfect, and we decide to wait until that x-ray until we give antibiotics. And that person ends up going to the emergency department. So with ultrasound in our back pockets, we could prevent that from happening. And when we look at the cost, it starts to become a little bit more meaningful. currently in 2023, there was a study, an economic study, looking at the impact of community-acquired pneumonia and its cost to the healthcare system. And if we think about the scenario where we're going to the emergency department, you're getting your x-ray, maybe some lab work, being sent home with antibiotics, it's costing the healthcare system approximately $1,600. And if that patient's admitted, so think about our frail, our young, kids, this actually goes up to around $12,000. This is a huge healthcare resource expenditure. And when you know that as a physician, that 5 minutes, that we saved, maybe that's not the real important thing to us. Maybe the physician fulfillment ends up going up, knowing that we're playing a part in reducing kind of morbidity and healthcare costs. And from a patient perspective, anybody that spent time in the emergency department, if we're saving 10 hours, that's a pretty significant thing, and that's going to lead to a lot of patient satisfaction. So I promise I talk about a logic model in this, and this is our logic model. This was created back in March of 2023. I presented it at Meredith Marks Day, and that really got into the nooks and crannies of it. But for those that have never been exposed to a logic model, essentially it's to kind of get everybody on the same page about what our outcomes are, what our program goals are, and then working back what we need to see from an outputs perspective, something we can measure, and the activities and the inputs that would be required to get there. And when we think about what we're doing right now, where we are a year after starting this program, we have some metrics here that I think are worthwhile noting, and there's a lot of them. And I really think some people might challenge this as being a baseline, which I think it is, but I think it's showing that we are working towards meaningful outcomes because we can measure all these, we can course correct, and that's the power of the logic model. So with that said, I'd like to hand it over to one of the really important areas here of this program, which is the research component. Victoria?
Yeah, thanks, Jason. So I'm going to summarize the research that's happened so far with regards to PoCUS in the last year or so. Mostly I'm going to be just summarizing the resident research projects, which were FMRSPs. And then Laura is going to talk more about the QI and QA that came out of our resident teaching. Jason, if you could go to the next slide, and then you could just skip ahead to the next one after that. So, and again, the residents kindly shared their projects with me so that I could present them today. So the first one I'll talk about, next slide, Jason, is Raj Walia, who's based out of the community clinic in Manotick. He was supervised by Jeffrey Hovey. His project was a survey looking at sort of resident and staff physicians' perspectives on PoCUS. And the first remarkable thing is that more residents had baseline PoCUS training than their staff physicians, which I think is important because it shows us that there's a keenness, there's an interest among our young learners, and also that us as physicians, if we're going to be supporting our learners, it's important for us to also have this training, as well as just to include it in our clinical workflow. The other thing here shows that there were some residents who did have this baseline training, and it was only those that had done at least 10 hours of training that could self-rate themselves as being confident in their skills. He also asked people to identify those scans that they thought would be most useful, which they commented on, first trimester scans for confirming intrauterine pregnancies, identifying consolidation for pneumonia, similarly to just what Jason was talking about, and then joint injections. And this is important just because, again, it sort of helps us to think about perhaps more carefully about what scans we should be teaching our learners when we're going forward with our curriculum. Next slide, Jason. At the Civic, this is a project I supervised with Adrian Frushescu, and he's Jason's resident, so also worked with him. And this was a project where he focused on using PoCUS as a clinical skills teaching tool. So he used it to try and see if he could increase resident confidence in determining fetal line presentation. And so what's exciting about this is that his intervention was didactic teaching as well as some hands-on teaching in our prenatal clinic. So what was accessible to anybody who wanted to attend was the didactic teaching, but he also attended prenatal clinics over several weeks to provide hands-on teaching with Leopold's maneuvers, again with an FMOB, but also with PoCUS to assess fetal line presentation. And what's remarkable here is just how confidence improved for residents after this intervention. So using PoCUS, we used it as a way to help them confirm that they were correct with their assessments with Leopold's. And so you can see here, although we, often think of PoCUS as an enhancement for our clinical exam, which is a very common perspective in the PoCUS community, it can also be really used to teach a clinical skill, which is important when we're trying to make sure that we're keeping up those traditional skills as well. And so I think this is a good kind of reminder that that's another way we can be using this. Next slide, Jason. At the Civic as well, I supervised Nimricon and Eugene Wang, who did a survey to look at how we were using PoCUS in the last year following the introduction of our resident training program. And there's a few important takeaways here. The most common systems that we scanned were obstetrical and lung. So again, maybe pointing towards areas that we should be focusing more when we're teaching our learners. You can also see that our survey capture rate was only 38%. So we only had 37 surveys completed, and in that same time range, about 96 safe scans. So definitely scanning much less than we expected, and even unfortunately maybe not fewer residents that had completed the training scanning as much as we thought they would. In terms of outcomes though, we did see that in the majority of encounters, PoCUS either confirmed the plan, and in other encounters, it changed the plan in that it made the clinician do something different than they intended on doing, which I think is meaningful. Both physician and perceived patient satisfaction were high, but really this did bring to light that there were definitely barriers that are impacting the opportunity to integrate PoCUS into daily clinical workflows at our site. And this is something Laura's going to talk more about in the QA section. And then lastly, so the project that's ongoing now and supervised with Jason is by Sada Seif and Adam Clayton. And again, lending to this idea of some of the things we've learned about that perhaps we have to focus more on indications that we're more commonly seeing in the clinic and that are more meaningfully impactful in our regular workflow, is looking at developing an algorithm for point of care for PoCUS ultrasound use in lung assessments and for respiratory complaints. So they're currently doing a literature review to look at its current use in primary care, and then with the aim of building an algorithm that would be both feasible and practical for regular use that we could teach and use more commonly in our clinic setting. I'm going to hand over to Laura now, who's going to talk about QI and QA.
Awesome. Thanks so much. I'll just dive right into it. Jason, if you could go to the next slide. Thanks so much. So an overview of what I'd like to touch on is, first, I'd like to share some of the findings from our initial pilot PoCUS curriculum that we did at the Civic. That was over the course of 2023. Then I'd like to build on what Victoria mentioned when it came to evaluating how we actually integrate the use of PoCUS into our clinic and some of the barriers there, looking more at the root cause analysis. So I've got a diagram sort of looking at multiple perspectives on QI. And then also I'm going to touch a little bit more on ongoing quality assurance and how we envision integrating that into the current workflow that we have at the Civic and elsewhere. A big thanks here to Adam Delcord, who gave us some lessons from Winchester, where they have integrated PoCUS and have a up and running QA program. And then lastly, I'm just going to touch on how we can move this a bit more broadly, where we can take PoCUS next. And again, sort of feeding back into the research that's been done, looking at other indications and how we can actually make this practical, useful, and valuable for not only us, but for the system, and how we can use PoCUS to address some of the gaps in care. So next slide. Thanks, Jason. So this is just a framework that I wanted to share. When we talk about quality improvement, it's always nice to have a framework to work from. And so I've here outlined our PoCUS education curriculum quality improvement project that we did over the course of 2023 using the Ottawa model for innovation. So we were very intentional when we made this QI project to follow a framework to make sure that we have the appropriate assessment of outcomes throughout the course of the QA project, and that we make it very systematic, so that we avoid making a big change and then realizing actually that perhaps the changes that we had hoped for were not actually coming to fruition. So the first step of this was to start by defining our problem. For us, it was quite clear based on the research that we had seen from some of the previous research done in Manotick and also throughout Canada, actually, there's a lack of curricula for residents in FMPoCUS. When it came to analyzing the situation and coming to find out, why is that so? It was actually quite clear in this case. We didn't really have to do a big root cause analysis. There's no curricula that are sort of universally available to residents, especially here in Ottawa, but also throughout the country as well. So we came up with a plan. We decided to do a test and a trial of a pilot program here at the Civic using a hybrid curriculum, and then locking in improvement. So now we have instructed the residents and we've improved, some of their confidence, but how do we sustain that confidence and how do we sustain that use of PoCUS on an ongoing basis so that then when they graduate, it's not a lost cause, that they actually are using PoCUS in their future practice and feel empowered to do so. And then the last step of the model is to sustain and spread change. So we've certainly learned a lot of lessons from our project. And so we hope that by having this and by sharing it at forums such as this, that we can hopefully encourage others to collaborate with us, empower them to see how it might fit into their setting. So next slide. Thanks, Jason. So looping back a little bit more in detail, when it came to defining the problem, this is just kind of a nice way of looking at QI is what's the current state and what's the future desired state. So our current state, our problem is that residents lack confidence and skills in PoCUS. They have no formal training. And our aim was that we were hoping that we could increase their confidence in PoCUS. Similar to the findings from Manotick, we found that residents, when we did a survey of them, only about 20% of them felt that they were at least somewhat confident or very confident on a Likert scale of 1 to 4 in terms of using PoCUS. And so we hoped that over a course of 6 months that we could increase that to 80%. We wanted to make it realistic, but we also wanted to aim high. And then when it came to that intervening step, the big why question is, why are they not confident? Well, because they've never actually had a lot of exposure to it. So next slide, please. There we go. Oh, perfect. So our change strategy was this hybrid curriculum. So we wanted to make it a curriculum whereby they had hands-on teaching, but they also had the opportunity to reflect and to build on their skills in an asynchronous format. So it was a hybrid flipped classroom format. They came prepared. We gave them the material, and then we had them do the hands-on, probe in hand. Our data analysis, we were very mindful to have outcome measures, process measures, and balancing measures. So our outcome was resident reported confidence. Our process measures were resident attendance. Of course, if they don't come, they're not gonna have the opportunity to learn. And then also skills assessments. So we looked at how many scans they did in clinic. We looked at if these were determinate, meaning that we actually could be clear on a yes or no to the PoCUS indication, or if they were indeterminate scans, the number of scans that they did in total. And then we looked at resident satisfaction and their time investment as well, being mindful that we didn't want to make this overly burdensome for the residents. And we also wanted to make it something that they actually thought was valuable and that they appreciated. So when we look at the outcomes, so when we tested it, we were very mindful to have lots of evaluations. So we started off by doing a baseline survey. That was where we found out that about 20% of residents were somewhat confident or more. And then we gave them access to the online modules. We checked again their confidence in PoCUS. Then we did the hands-on teaching. Again, immediately post hands-on session, we did another survey. Then there was a period of about a month in between sessions where they were able to reflect. They were able to go back to the modules, refine some of their knowledge, and then came back to the last session. We checked their confidence immediately before the hands-on session and then immediately after. And I think the really interesting thing here is, first of all, we see that there is this overall trend towards improved confidence. And it was great. We actually had 96% of residents from 20% After the course, 96% felt that they were at least somewhat confident in PoCUS skills across 6 core indications. But we also see here that their confidence improved sequentially from the online modules to session number 1. Then when they went away and there was about a 4-week period, it did decay a little bit. So we see that if we don't continually practice those skills, we start to lose our confidence. We start to be a little bit less sure of ourselves. And then when they came back to that last session, there was actually an even higher rate of confidence. And so what that shows us is that the more that we have these periods of kind of going away, reflecting, having access to teaching, and then continually reinforcing those skills through use of PoCUS, the better off our residents are. Next slide. So now this speaks to the importance of, we actually need to have them scanning. We need to have them in clinic. We need to have them with probes in hand. And so now we're looking at what are the barriers, because as we saw from Dr. Wang and Dr. Khan's research, there are some barriers, it seems, to actually having them use it on an ongoing basis. And this here is an Ishikawa diagram for those that do QI, which I'm sure a lot of you are familiar with. It's a nice way of breaking it down. And we've already started to look at some of the barriers and how we can address those. So for instance, not having the probe charged, not having the tablet charged. We now have a central docking station in the clinic. All the residents know where it is. We've also encouraged them to use their phones rather than a tablet, so there's less kind of wires and sorting that out. We've given them their logins. We do plan to give a more structured teaching around the use of the Butterfly app and how they can get up and going with that. We've made templates to address the documentation requirement piece. I'm going to speak more about quality assurance and how we're going to get that up and running. We have more supervisors now at the clinic. So myself, Victoria, we got certified. Usama over at the Riverside is getting certified. So we can have that capacity towards teaching. And then we also have a protocol for addressing incidental findings as well. So we've been chipping away at these as we move through. Keep going. Thanks. So now this speaks to the next step, which is quality assurance. So quality assurance in PoCUS means that we have a central database whereby all scans are logged, and then there is a skilled clinician that can review these and give feedback to the learners on their image acquisition and their management. So it provides opportunities for feedback on an ongoing basis. It promotes patient safety, continual improvement in our technique, and also it is a pathway towards certification. So if residents have a log, they can then submit those to cPOCUS, which is the Canadian PoCUS certifying organization, and they can get their certification. Next slide, please. So the building blocks. So we need to have an archiving system. We already have that. Big thing is that a lot of the residents aren't clear on how to archive scans and how to use it. So we plan to now build on our curriculum so that we actually have a dedicated session on how do you actually scan things, how do you archive scans now that you have the confidence in using PoCUS. We spoke about how there wasn't a lot of archived scans that were seen in the research done by Dr. Khan and Dr. Wang. So we're hoping that we now have a billing code where they can just put in a billing code and we can actually track how many scans are being done. And then out of those scans, how many are being archived so that we can see, is there a rate limiting step between doing the scan and actually archiving it, and hopefully address some of the barriers there. And then the other big piece is that we need to have certified PoCUS supervisors who can review the images. And the biggest piece here is time. So we're planning to collaborate more with Dr. Delcourt, who is having this up and running in Winchester. Next slide, please. Almost done here. So now when it comes to sustaining and spreading change, so I've put a little tree here. We've planted the seed. We're hoping that this can grow into a nice big tree that can be implemented elsewhere as well. So ongoing review of measures, we want to make sure that our data measurement is sustainable, intentional, and integrated. So using a billing code that's integrated into our current workflows, making sure that our evaluations for residents are not overly tedious, because we know that if they're a barrier, if it's another big form that they need to fill out, it simply won't be done. We want to capitalize on our existing infrastructure. So we're hoping that we can integrate this into their hospitalist rotations. That's already a great setting for them because there's lots of patients, there's lots of acuity, there's lots of findings, and there's also more day-to-day flexibility when it comes to finding time to do PoCUS. And then lastly, we're hoping that we can empower others to spread our findings and integrate them into their settings. So we've shared some lessons learned here, and then we also are hoping to kind of whet people's appetite through ongoing CPD. Thanks.
Thanks, Laura. So this is going to be quick, guys, to wrap things up. My apologies for being a little bit over. try to keep in the whole. If anybody hasn't noticed, we are kind of taking kind of a technology approach with our sections here. So this is the upgrades, the next step section. Oh. So I'm going to break it down into what we're going to continue, what we're going to continue to do, what we're going to start to do, and what we're going to change. So, and maybe in a different order. So first thing I think we've seen here is that tracking our progress objectively is going to likely lead us to our desired outcome. So the use of this logic model as a scaffolding system so that everybody's talking the same language is really important. Doesn't mean we can't update it, and that's fine. It's a pretty tedious process. I'd be open to that. But with that said, we're going to keep on using that. We're going to continue with the research component of this program. As you can see, it's opened up a lot of insight into actually where we're going. And we wanted to be focused on feasibility, health impact, and innovation. We're going to continue with the flipped classroom approach. I think this has been efficient and effective, and listening to the residents in the feedback that we've gotten, it's been an effective way for them to have a resource to go back to. And so we're going to kind of continue to use that approach. It's also scalable. So it's also something we can, once made, can share with anybody, any site that wants to use it. We're going to continue supporting the PoCUS community. That includes kind of teaching with UGME, reaching out to our colleagues in emergency medicine and internal medicine, and trying to reach out to community preceptors to get them exposed, as well as the learners, of course. What we're going to change, well, you know, as we've kind of alluded to, we had an initial assumption that we need to have building block scans leading into the more difficult scans. And I think what we're seeing is that there's a need for things to be feasible in order for them to get done, which makes sense, I understand. And as we've progressed and matured with this program, I think we're going to be really focusing on a core 3 to 4 indications to start out with that we feel are high yield in the outpatient setting. And this is a tentative list. You know, we have to really look at the model, everything, everywhere, all at once. As you can see, we're learning a lot about the process. And so expecting a zero-shot or one-shot approach to curriculum development is kind of tough. So maybe, you know, through small introductory sessions, we can kind of pique curiosity. And in May, I am going to be giving an hour-and-a-half introductory session to the residents about ultrasound. It's going to be tough to get a lot done in that period of time, but what we will be able to do is at least introduce the broad strokes and introduce safety. Also, I think that we have to be, you know, honest and look at, you know, there's lack of uptake at many sites. There's many barriers towards this. You know, it could be that PoCUS isn't the right fit for some settings. You know, we have to figure out how we get probes out of boxes and probes into hands as well, because I think this is a big rate limiting step. And obviously there's a lot of challenges to that. You know, there's a lot of challenges from a cost perspective and things like that. So, you know, we're working on that, but we may want to revisit this model and maybe start with people that are organically interested and move up from there, and that are committed, obviously, to being part of the teaching process. Because as you can see, this is very much needs to have a teaching focus. What we're going to start doing, well, we're going to start to look for new teaching models, or we're going to start to incorporate new teaching models, I should say. Peer-to-peer learning has been seen to be very effective in just a small amount of research projects that we've had going, but this is actually evidence-based in a lot of the PoCUS literature. Our UGME colleagues have actually been published on this method, and actually it's very effective teaching models. We want to use the tools that are available. We have to work smart, not harder all the time. And so with the development of artificial intelligence, and I know it's a kind of a buzzword that gets thrown around, there is some interesting, innovative ways that we can actually have residents have independent learning resources. And even the Butterfly IQ, its ecosystem has that available. We're going to start doing QA. We've been doing it bedside, but now we're going to move to the technology so that we can reach its full potential. And we're going to, you know, start to look at offering local FM PoCUS courses through the CPD department and Dr. Wool-Torton through TOH2. And so I think that's something that that is going to decrease those friction points to getting people involved in PoCUS. So there's some references. My apologies for going a little bit longer, and I thank you for your attention, and open up to any questions if we have a little bit of time.
Well, thank you so much, Victoria, Laura, Jason. Great to hear these QI initiatives for PoCUS, the resident projects, and sort of and these next steps to moving PoCUS forward. It's my pleasure now to introduce our second speaker, and that's Ramtin Hakimjavadi. And Ramtin is a medical student, class of 2024 here at the University of Ottawa. My, how time flies, Ramtin. And his research interests are primarily focusing on health services and digital health for use in the older adult population. So Ramtin, I'm going to hand things over to you.
Thanks for that introduction. My name is Ramtin Hakimjavadi. I am a fourth-year medical student at the University of Ottawa. And today I'll be speaking a little bit about the research our group is doing using eConsult to conduct health services research on frailty. So I have no conflicts of interest, but I would like to acknowledge our partners who have been involved in many steps of our research. And just to give a little bit of an introduction about myself and how I started research. So about 4 years ago, I had an interest in digital health. So I learned about eConsult and the work that Dr. Claire Liddy's team had been doing using eConsult. So I reached out and she was gracious with providing me opportunity to get involved. And I initially got some seed funding through the Ottawa Europe Scholarship, which helped me get a start and have my first presentation. But crucially to the topic of today's presentation, I received a scholarship from the Canadian Frailty Network, which led to the publication and the results that I'll be discussing today. And so here's a snapshot of what I'll be going over today. So first is a little bit about eConsult for those who may not have heard about it and some of the research applications that are possible with this technology. And then more about frailty and how we're using eConsult to study frailty and some of our current work and future directions. So what is eConsult? eConsult is a digital health innovation created by physicians for physicians. Dr. Claire Liddy and Aaron Keeley started this over 10 years ago. And it's a tool where primary care providers can log in and ask a patient-specific question to a specialist and receive a response from said specialist in 7 days, but also, often very less than 7 days. But today's focus is more on the research aspect. And what I'd like to focus on here is the rich data that eConsult generates that we're able to use in research. When a PCP submits a question to a specialist, it initiates a conversation where we can look at that text and ask different questions and analyze it from a qualitative and a quantitative perspective. And then there's also service utilization metrics that we're able to see, such as how long, how much specialist time was billed, how long did it take for the specialist to respond, and then there are also some patient demographic information as well. But for the focus of today and the research that we'll go over, it's really that text, which is the conversation between the primary care provider and the specialist that I'll focus on. So now about frailty and how we're using eConsult to study frailty. So frailty is a condition that I think all clinicians are aware of, but it's variably defined in the literature. And we know it's a multifactorial syndrome. It's associated with aging, and it's characterized by an increased vulnerability to stressors and decline. We do know that early recognition can improve outcomes for older adults living with this condition, and that's why primary care is a real focal point for these individuals. Tools for helping primary care providers identify frailty in the primary care setting are lacking. which led us to ask the question, could e-consult be used to help identify frailty in the primary care setting? And this was one of the initial questions we asked when we started researching frailty using e-consult. Perhaps the communication between the primary care provider and the specialist provides some clues or some details that we can use for clinical and research applications. These are some initial research questions that we asked when we decided to pursue this research. So is there even sufficient information on e-consult to make inferences about the frailty status of the patient being described? If we look at the frailty-related terms, would we find more frequently these terms in cases about long-term care residents compared to those living in the community? Because we know, or we make the inference that those who are living in long-term care are more likely to be living with frailty than those in the community. So we expect a higher number of terms in cases about those individuals. And finally, if we ask clinicians to read e-consult cases and then count the number of frailty terms in the same cases, would we think there's agreement between their ratings and the number of frailty terms that we find? So these are some of the initial questions we asked. And these are the findings from that study I referenced earlier, and I'll be going more into these. This is the first publication our group had where we used e-consult to study frailty. This is just an overview of the methods. We looked at cases from 2019, and our population was a one-to-one matched cohort of long-term care residents and community dwelling older adults. And we analyzed these cases in a quote-unquote machine-driven manner and a human-driven manner. And I'll get more into what we mean by that. In the machine-driven manner, we came up with a list of frailty-related terms by doing a literature review to see what terms are commonly associated with frailty. And we also got input from our multidisciplinary team of clinicians, researchers, and care partners. And then we developed a Python program to count these terms in the text, and the text being the conversation between the PCP and the specialist. The human-driven manner was where we asked two of the long-term care clinicians on our team to independently review the cases and provide an assessment on a 5-point Likert scale, assessing the likelihood that that patient is living with frailty. So this isn't a severity of frailty. So 5 doesn't mean severe frailty. It just means a high likelihood that they think this patient is living with frailty. And then we compared long-term care cases to community cases. And one of the premises that we had, or assumptions that we had in this research, was that the clinician ratings and the frailty-related terms would be higher in long-term care cases than community cases. That's what we thought, because we could identify with high confidence those living in long-term care. And we suspected that those living in long-term care would be more likely to be living with frailty compared to the community. This is a really busy table, but essentially it's just showing the frequency of terms that we found in our overall cohort. So on the left, you'll see the frailty topics, the top 3 being dementia, walking difficulty, and falls. On the right, you'll see the specific terms that were found in the actual text. This is just to give you an idea of the sort of terms that we were counting in the overall cohort. And now this is a breakdown of long-term care versus community cases. And I'll just point your attention to the fact that in long-term care cases, on average, we found almost 5 frailty-related terms. However, in the community cases, we found on average 2 frailty-related terms, which was aligned with our hypothesis. And we also found a higher proportion of cases with at least 1 frailty-related term compared to those in the community. And this is also a neat figure. On the x-axis, those are the number of frailty-related terms per case. And on the y-axis is the frequency of cases. As you move from left to right, you can see that the number of community cases decreases relative to those in long-term care. And when you get to more higher numbers, especially like more than 10, it's essentially only long-term care cases. So we were finding a higher number of frailty descriptors in cases about residents living in long-term care. And this is the last diagram that I want to show you. This is showing our clinician-provided frailty ratings, and I'll draw your focus to the left side. On the x-axis, that's the ratings that the clinicians provided us. And you can see that when they provided a rating of 5, meaning they gave a high likelihood that this patient being described was living with frailty, there seemed to be a cutoff on the y-axis around 5 terms. So if there was 5 or more terms, there was a high likelihood that a clinician reading this case thought that this patient was living with frailty. And that was really interesting for us to find because it allowed us to kind of create a classification for frailty cases for future research. So what did this research show us? So it essentially showed us that it was feasible to use eConsult data to make inferences about the frailty status of the patient being described with some assumptions. And it also gave us a feasible way of classifying cases as quote unquote frail or not for future research. And so the question is, what's next? What did we choose to do next with this information? There are clinical and research applications that you can use to study frailty using eConsult, but one thing that I'll focus on for the remainder of this time is how we're using it to explore the educational value of eConsult for frailty care. So eConsult and continuing medical education, our group has done a lot of work looking at the questions that PCPs ask on eConsult to identify learning needs. One of the next steps we're taking right now is to identify these learning needs with respect to frailty. So actually, relatively little is known about learning needs related to frailty care. And traditional needs assessments, such as surveys or focus groups, rely on people's subjective assessments, which can be inaccurate. But if you look at the questions that people most frequently ask while they're at work and when they actually need this knowledge, it's actually quite accurate, an accurate representation of their learning needs. Sort of if you look at someone's Google search history while they're studying, you probably have a pretty good idea of what they would like to learn. And that's what we're doing with eConsult in this case. We're looking at the eConsult cases that we categorize as quote unquote frail, meaning that the individual being described is living with frailty using the methods we developed in our previous study. And then we're looking at the questions asked on those cases to see what the learning needs are associated with frailty. And the thought is that this will help inform future continuing medical education that is tailored to the needs of primary care providers. So I just like to acknowledge my supervisors who invited me here today and have been supporting me for many years, and also the DARE team, many of whom I think are here today. And if there's time, I'm happy to take any questions. Yeah, thanks for listening.
Brampton, thank you very much. Great presentation, great study, and glad to see that this work got published. It's great. Well done.